A lot of you guys wanted to hear more about PSOs, and so this talk is going to be about cervical PSOs. And PSOs are very powerful sagittal plane correction operations, but they carry a very significant risk and complication profile. So we need to be really careful about the indications, right? Because you can do some harm with this operation. So the indications for a cervical PSO would be a severe deformity, first of all, that's fused in kyphosis. Now it needs to be severe because there's potential for significant morbidity. And if you look at the experience of a lot of people, including Ed Simmons, he was an old-time spine surgeon who really popularized cervical osteotomies. And he didn't do PSOs, but it was a 3-column osteotomy, but I'll show you exactly what he did. But I think the risks are similar, perhaps a little bit worse with his technique. But 131 patients with 2-year follow-up. And basically what he would do is a posterior column osteotomy, so you take down the facet joints and do a wide laminectomy. And then this was back in the old days, so he would take the head in a halo and just kind of crank it backwards. And you would literally osteoclase or break through the disc space anteriorly. So what ends up happening is that you lengthen the anterior column and you shorten the posterior column. And so the downside to this is that you can lengthen the soft tissue structures of the neck, the esophagus, you can lengthen the vascular structures, and you can imagine that that could have consequences. So here's some figures from his paper. It was done awake with local anesthesia and the patient sitting in a dental chair. He would do this sort of wide laminectomy, facetectomy, and foraminotomies. And then I love this description of the osteoclasis. The surgeon grasps the halo securely and brings the neck gradually into an extended position posteriorly as osteoclasis occurs anteriorly. Audible snap and sensation of osteoclasis are usually noted. They didn't use any internal fixation. They put them in a halo for 4 months and then a SOMI for 2 months. But you can see they got really good correction out of this operation. But it came at a cost. You know, they got about 50 to 60 degrees. And actually these PCOs, if you do something like this where you circumferentially release the spine, I mean, you could literally put the spine in almost any position you want. But that, you know, there's risk to that, of course. Neurologic complications, there was one intraoperative paraplegia that he thought was due to infolding of the dura, and so he did a duroplasty and it resolved. One patient was permanently paraplegic. There was one hemiplegia due to carotid distraction injury with a stroke. Again, you're lengthening the anterior column. And there were 18 transient C8 radiculopathies, and that's a common theme that you'll hear with this operation. 4 deaths as well. So the modern PSO literature is not the greatest overall, but it suggests probably around a 25% neurologic complication rate. Thankfully, most of these are not spinal cord injuries. They tend to be C8 root palsies, which typically are transient. Here's a study of 78 patients published in Neurosurgery by Smith. The overall early neurologic complication rate, or overall complication rate, was 44%. 28% had at least one minor complication. 24% had at least one major complication. 1.3% risk of death. So this is a big deal. It should also be a fused deformity. Okay, so if this is a really key principle, if there are available non-fused motion segments, use those to gain correction. Don't necessarily go to a osteotomy. So here's an example of a 76-year-old man. He had progressive kyphosis after he had had a laminoplasty and an ACDF by some other local surgeons. You can see that he's moderately kyphotic and has pretty significant positive sagittal balance, a lot of neck pain as a result. You look at his CAT scan and he's autofused at C2-3, C3-4, and then a surgical fusion and kyphosis at C6-7. But that means he has some available disc spaces that you can use for correction. So what we did here was a 2-level ACDF from the front, and then a C2 to T3 fusion with some posterior column osteotomies for additional correction. You don't necessarily have to go to a PSO for these sorts of cases. Here's another one, a 53-year-old man, chin-on-chest deformity. He had dropped head syndrome due to idiopathic neck extensor myopathy. And again, he's not fused. There's open disc spaces. There's not a whole lot of correction, but there is some correction. And so in a case like this, we did multi-level ACDF and then a posterior fixation and fusion. Again, utilizing open disc spaces and not necessarily doing osteotomies unless you absolutely have to do them. So in terms of the technique of a PSO, basically a cervical PSO is not going to be any different than a lumbar in terms of basic technique. You go in the back, do a wide laminectomy. You take out the facet joint above and below the level of the osteotomy, and then you enter into the vertebral body and remove the posterior 2/3, take out the pedicles, implode the back wall of the vertebral body away from the dura, and then you take this wedge of bone out laterally so that then you can apply a correction force to close down the osteotomy and get the correction you need. So here with a PSO, as opposed to the posterior column osteotomy, you shorten the posterior column, but the anterior column remains unchanged. So, these people are still at risk for dysphagia and whatnot, but you're not necessarily stretching them out to the extent that you would with that sort of 3-column osteoclasis procedure as done by Simmons. So here are a couple cases. This is a 63-year-old man who presented to me after 15 previous cervical spine operations. Believe it or not, 15. They were all done by the same surgeon. And he was fused solid in kyphosis from C1 to C7. So we did this PSO at C7. And actually, I got better correction than this in the sagittal plane in terms of his CSVA intraoperatively, but for some reason, every time I extended him a little bit more, the signals would get a little wonky. And so that was the level at which we had stable signals, and so we accepted that. But you could see on the CT scan through that very abnormal vertebral body that we got about 40 degrees of correction. So the question arises as to what level to do the PSO. So classically, it's been done at C7. You have to identify and make sure, however, there's no vertebral artery at C7, which about 10% of people do have. But the benefit of C7 is that it's an intrinsically more mobile segment. The vertebral body is small, so you don't have to do as much work to do the osteotomy. But the downside, as you might have heard, is that it can really have a high risk of hand function issues. C8 palsy, again, literature suggests about 25 to 30% of patients will have some hand weakness post-op. So the other option is to do it in the upper thoracic spine. And if you do T2, that's usually going to avoid issues related to your hand function. You also have a taller vertebra. So again, going back to math, if you think about a tall vertebra and you take a wedge out of it, you could potentially get more correction versus a short vertebra. You also will almost always be able to put pedicle screws in above and below. And so you have some more corrective force to close down the osteotomy. But in my opinion, the downsides, there are a few of them, although I typically will do them in the upper thoracic spine, all things being equal. You have to resect the ribs. It just requires a little bit more work. It's an intrinsically less flexible area, and it may be very far from the apex of the deformity, although maybe you can get some better sagittal alignment correction because you're more distal. So here's a case of a 68-year-old woman. She had had multiple front-back surgeries done elsewhere. She came in after her most recent operation with progressive myeloradiculopathy and difficulty holding her head up. Her chin wasn't quite on her chest, but you can see it's really close. I called it chin near chest. But it was a very stiff, non-reducible kyphosis. She didn't have any neurologic deficits. If you look at her MRI, she's got residual cord compression at C3-4 where she had the previous operation. There's also a spondy at T1, T2, causing very severe cord and root compression. And then on the axial cuts, you can see the residual compression at C3-4. There's also some at C6-7, which is not that bad, and then really, really severe at T1, T2. On the CT scan, to top it all off, she's got C1, C2 arthritis. There's the OPLL that was never removed with a previous operation, and then she's solidly fused in kyphosis from C3 to C6. So what are you going to do in a case like this? Well, one option is to do a 2-level revision corpectomy and take out the OPLL and do all of that. But the more I thought about that, it wasn't terribly attractive to me. It could get messy, big dural leaks. And if you think about it, just doing that's not going to correct her deformity, right? So the other option was to do a T1 PSO because in association with a upper cervical revision laminectomy, because by doing this, you achieve two things. Number one, as you realign the spinal cord can drift away from that OPLL at C3-4, and then you can also relieve the root and cord compression at T1, T2, where there was severe compression. And so post-op, you can see, again, about 32 degrees through the osteotomy at T1, and these are the x-rays. She was able to stand with her chin well off her chest now, and all of her neck pain and arm pain went away, and the myelopathic symptoms went away. The other thing you'll notice is the abnormal contours in her thoracic and lumbar spine became much more normal post-op as well. So these are powerful operations, but use them only when absolutely indicated would be my suggestion. Thank you very much.